Hello, my name is Cam Kalontar. I'm a nephrologist from Southern California, and I'm privileged to moderate today's session. It's a panel discussion within the session titled Words Matter, Standardizing CKD Nomenclature to Improve Patient Engagement and Communication. Today's session highlights patient's perspective, the history of current CKD nomenclature, and novel efforts to improve patient engagement. We're joined by our four panelists. We start with Dr. Edgar Lerma, who is a practicing nephrologist and a recognized nephrologist, adult nephrologist from Chicago area. Then Mr. Paul Conway, a kidney patient leader from the American Association of Kidney Patients, will join us. Then we turn over to Ms. Sharon Rouse, who also represents American Association of Kidney Patients. And we are also privileged to have Dr. Marva Maximems, a pediatric nephrologist and chief of nephrology in Children's Hospital of Washington, D.C. Without further ado, I would like to invite Dr. Lerma to tell us more about KDIGO nomenclature.
Thank you very much, Dr. Kalantarzadeh. So I just want to show you that back in June of 2019, the KDIGO group convened an international consensus conference with the goals of standardizing and refining the nomenclature used in the English language to describe kidney function and disease, and developing a glossary that could be used in scientific publications. And this is also to facilitate communication within and across disciplines and between practitioner and patient communities to ultimately improve outcomes through clarity and precision. So why come up with this nomenclature? So you could see here on this slide, for clinicians and health professionals, this would reduce confusion and errors in clinical practice, promote consistency in research, and also raises public awareness. And then for patients, facilitates communication between healthcare provider and the patient. It takes into account patient preferences and her needs and values. And then also it minimizes the language ambiguity and mobilizes self-management and advocacy. Now, this conference was based on three guiding principles. It is patient-centered, it is precise, and it is consistent with the KDIGO guidelines. Next slide, please. So the key take-home points are as follows. The conference, which is composed of different editors and editorial board members of various peer-reviewed journals, which of course included Dr. Kalantarzadeh. Here are the key take-home points. Use kidney rather than renal or nephro when referring to kidney disease and kidney function. Use kidney failure with appropriate descriptions of presence or absence of symptoms, signs, and treatment. Use the KDIGO definition and classification of acute kidney diseases and disorders and acute kidney injury. Use the KDIGO definition and classification of CKD rather than the alternative descriptions to define and classify CKD. And lastly, use specific kidney measures such as albuminuria or decreased GFR to describe alterations in kidney structure and function, respectively.
Well, thank you very much. Thank you, Dr. Lerma. That was excellent introduction. I would like to now ask Mr. Paul Conway to kindly share with us about his interpretation and the goals and other comments. Paul.
Great. Thank you very much, Doc. And it's a pleasure to be with everyone here at Kidney Week. So since 2019, when KDIGO pulled together their discussion and published their paper, at the American Association of Kidney Patients, we've been following this for quite a while, this issue of language. And I approach this as both a patient of 40 years and also as somebody who's trying to widen the base of people that are involved in innovation in the kidney space well beyond the field of kidney disease to include engineers and scientists and researchers in many disciplines. And so when I took a look at the debate, I decided to take up an opportunity with C. Jason to do a patient editorial on the paper that Allison Tong and others had put out, underlining the key concepts and saying that it's long overdue, that the use of plain and understandable language is important. And I've watched this debate unfold. And one of the papers in UCAM, we're an author on one of them that came out, gave a very, very impassioned view of not mandating. But in the discussions, I thought it was important to bring out the fact that this use of language is something that's been around for a long time by leaders. And in the first slide here that you have George Orwell and his 6 rules of improving writing for understanding and communicating. And I brought that up because Orwell is cited in your paper on the importance of language being clear in communications. And in fact, his rules actually say that. But to step back, I wanted to draw an analogy between what's going on in kidney disease and 2 great leaders, one of whom, John F. Kennedy, in his own writing, and then you can see his own handwriting in this slide, in his speech on putting a man on the moon, which was delivered in 1962 at Rice University, he drew a picture of what innovation could hold. It could drive great change and great promise through a vision. And he used language in very plain terms to communicate that. It defined an entire generation. In fact, it was the new frontier. And in another example, you have a picture of Ronald Reagan, who used language and a challenge in very plain language to tear down this wall, to essentially put a challenge out between 2 competing world systems, communism and democracy. And through plain language, he was able to achieve, working with many others, great change. And it was a challenge to the status quo. And so for us as kidney patients, when we take a look at the debate that's going on about this, I think it's important to understand that language within the field of kidney disease and kidney disease research has not been inviting to create a larger base of people that want to participate in driving change. It's very insular. It's largely academic. And if we're trying to build the base to drive innovation and create artificial organs and to invite people all over the world to participate, your language and your vision has to be clearer. And it cannot be isolated and siloed simply within the field of kidney disease. And so we welcome the debate. We thought it was important. And the means of achieving this through mandate is not what I was weighing in on. What I was saying is it's a timely discussion. And so I think it's important for people to engage in this. In my experience as a patient, when I was first diagnosed, I was told that I would have a very, very limited lifetime. And I had a bunch of medical terms. I asked the doctor to put it in plain language. And what he could not communicate to me was how my diagnosis was going to interfere with my aspirations and my choices. He simply could not articulate it. I found another doctor. That was almost 40 years ago. And so the time is now, I think, for a change. And I think this is a very healthy discussion. Thanks, Ken.
Well, thank you, Paul. With the keyword choice and aspirations, I would like to ask Ms. Sharon Rouse to join us with this discussion. Sharon.
Thank you so much. I'm privileged to be here and to also be able to be a patient voice for those of us that are faced with dealing with kidney disease on a day-to-day basis. Words matter. I mean, to me, that's the bottom line. Words matter. And no matter who you're talking to, whether it's a doctor or a patient, it's still going to matter. And so for me, in my experience, like Paul, I too, you receive all of these definitions and terms and things. And so I found it that I had to research it for myself. I had to go to Google and put it in to figure out what my doctor was saying to me, and to even understand my condition and what I was up against at the time. And so words do matter. And I also think, beyond that, how am I to establish a relationship with my physician and those that are responsible for my care if I don't understand what they're saying to me? And so, I think my takeaway is that this definitely has to continue. The conversation has to continue as to how we can better educate. I'm more apt to participate in my care if I understand what's being said to me and how we can work together as a partnership, not necessarily, giving all of my care to the doctor. I always look at it as a partnership. I play a part in it as well. But if I can't understand what you're saying to me and we can't have a cordial communicative conversation, it's going to be very hard for both of us. And so sometimes we find patients aren't compliant, but I wonder if it's because of the language that's being used. And maybe they don't understand. They don't understand the part that they play in it. They don't understand the terminology and how to communicate effectively with their physicians. And so the bottom line for me is words do matter. And so it's up to us to work together to iron this out and to hash this out because lives depend on it.
Well, thank you very much, Sharon. Very nicely said. Let's now switch over to Dr. Marva Maximems, who is a hardworking pediatric nephrologist. I mean, everybody's hardworking, everybody's committed. But being in Washington, D.C. and in charge of the nephrology division of the Children's Hospital of Washington, D.C., that gives also additional perspectives. Marva.
Thank you. And first of all, I'd like to thank the organizers of this session for inviting me to be part of this. I do think that I have a somewhat unique perspective compared to members on this panel with regard to communication of kidney disease issues to patients. First of all, I can't come out against this, right? This is the mom and apple pie. Of course, we want to be able to communicate with our patients. And as a pediatric nephrologist, that's something that's been forefront in my practice from the beginning. I have to make it clear, not just to the caregivers, the parents of the children that I take care of, I have to make it understandable for the kids. So I really have to break it down. I can't have a conversation at such a high level when the child is sitting there that, you read the paper by Dr. Tong and others, and they talk about how terrifying people find it when they're having these conversations. Can you imagine, as a child, how much more terrifying that is to see your parent having a discussion with a physician and you have no idea what they're talking about? So I say that to say that I'm used to breaking it down and making it simple and understandable. So I absolutely advocate for that. I think that is what we should all be doing as physicians, not just in nephrology, but in all aspects of medicine. Where I think I align somewhat with Cam is, to me, what's happened with the KDIGO guidelines is there's been kind of a conflation of better communication with our patients and telling us how to write in the medical literature. And this is my personal opinion here. I'm an associate editor on a journal, so I'm not speaking for the journal. And I think we can have our cake and eat it too. I love the words that we use in nephrology when we're engaged in the scientific discourse and the discussion of the pathology. And I know some people may think, oh, it's very flowery language, but it's grounded in, Latin, the Romance languages, et cetera. And so we understand those definitions. So I think personally, there ought to be a distinction between clear, plain language when we're communicating with patients. Absolutely. We need clear, plain language when we're communicating with each other too, but those two don't necessarily have to be exactly the same. And I hope I'm not muddying the waters here, but I do think there is a way to have our cake and eat it too.
Well, thank you, Marva. So maybe with that, I can share two slides maybe. So after this great discussions, but for panelists, I would like just to share 3 of my slides. One is that Eskimos have more than 50 ways to say snow. They still say snow, but given that they deal with snow more frequently than many of us, for them, snow has a different maybe connotation. My second slide is here. Aren't there more important kidney priorities? Vestiges of structural racism. This is a great time to join and to give a shout out to what is happening essentially after 20 plus years of having race as part of EGFR is being removed. This was a teamwork. 30-day readmissions. Each time a dialysis patient is admitted to the hospital is being pressured to stop dialysis, and I see there is no advocate. And I feel that this is another important thing, patient-centered dialysis modalities, working together on slowing the rate of progression by lifestyle modifications, effective symptom management so that patients do not need to continue to suffer, and teaming up to ensure that patients can live long and well with kidney disease. So I think nomenclature is very important, and I always insist on using the word kidney. Kidney, I'm coming from a division of nephrology, which has the name kidney. It's called Division of Nephrology, Hypertension, and Kidney Transplantation. We push for across the process and our leadership in our university to get the word kidney in the designation of our nephrology division. So with that in mind, I would like to turn it over to back to Edgar. Let's start from Edgar again. And without having more slides, let's continue this discussion. So Edgar.
So, I think, well, first of all, I agree with the sentiment that it is important to communicate with our patients in a way that we are all on the same plane. I get it. I get that the word kidney, when I introduce myself to my patients whom I'm meeting for the first time, I would tell them, my name is Dr. Lerma and I'm a kidney specialist. I don't say I'm a nephrologist. I don't say I'm a renal specialist. I say I am a kidney specialist. And that gets to the point. And then we start discussing. However, if I put my other hat on, as you know, Cam, I've edited a few nephrology or kidney books. And there are terms that don't go well with kidney directly. I'll give an example. When we say renal tubular acidosis, right? We all refer to it as RTA. It's a little bit odd to say it's kidney tubular acidosis or KTA. So from the editor's perspective, there's a challenge. Although there are some words like we can change renal tubule to kidney tubule. We can change sometimes the renin angiotensin aldosterone system is not going to be kidney renin angiotensin aldosterone system. So there's some peculiarities. And then I think the other thing I want to bring up is, and this has been brought up in some of the editorials that were written, the comment that you made about the Eskimos. You know, the word kidney is Anglo-Saxon in nature, and most of the terms we use in medicine are Latin based, and so with that, I think there has to be an understanding of that as to why the word renal has been inbred in the nephrology community forever until this time. So that's kind of my take up on that right now.
Okay, thank you. Let me ask Paul. Paul, I'm going to make one quick comment. Cardiac versus heart, renal versus kidney. Why should kidney be more sensitive than heart versus cardiac?
Because I think people ought to take a look at what the biggest picture is here. We have the opportunity right now to revolutionize and change how people view kidney disease, to bring more people into the discussion about fighting kidney disease, and to revolutionize care. But if we don't think beyond this community, if we don't get outside the academic ivory tower and invite more people to the discussion, it's not going to happen. That's just plain. And so as we're taking a look at this issue, the reason why renal and kidney is important is because right now, across the globe, this is the time for change. And if we don't understand that you use different types of language on the same issue to communicate to different audiences, to invite people into a larger enterprise, the opportunity to change, then we're going to miss the moment. That's why I used two great leaders of the United States who were very well educated, actually, and knew what they wanted to do, but their vision never became untethered from the audience that they sought to enlist. In John Kennedy's example of put a man on the moon, he knew that he would bring all of the researchers and technologists from many different fields, but his audience was the world, because what he was juxtaposing was a free and democratic society putting a person in space to invite collaboration, not to militarize it. It was a very bold vision in very plain language. To Reagan, he sought to change the status quo, much as we are doing in the field of kidney disease, away from status quo kidney care and dialysis. Reagan's vision was to topple the communist enterprise, and that was done. But it was done through plain language and very aggressive foreign policy, but it captured a vision. And my point here is we're at the same moment. That's why in 2019, as KDIGO convened an academic conference in June of 2019, the American Association of Kidney Patients put out a statement saying that we declared the coming decade the decade of the kidney. And what that meant was 10 years of innovation, renal replacement therapy, and 100% patient care choice, meaning the patient was now at the table. The patient was at the center of driving care choice, and that as consumers, we wanted innovation and we wanted to reject the status quo. In order to do that, you have to invite many more people into this discussion, and we need to select the language that is understandable to many different audiences. In looking at some of the clash of cultures here about this issue, what's fascinating to me is there's an expert at MIT in organizational change, Dr. Edgar Schein. And in his analysis, what he's looked at is different institutions that are going through change. The higher the degree of education, the more identity people draw on the language and the cultures that are used, that they draw relevance from. And I think that's an important point here in the field of kidney disease. It's a very highly educated field. And the anxiety and fear that people have that their status and their relevance might be reduced by changing language, especially among doctors and researchers, I think is important to put on the table, because I think there's a lot of trepidation and fear. What we're saying as patient advocates is, step beyond the fear and understand that you have a huge role to play in getting more patients involved in research, increasing patient involvement in their own care, and driving innovation. And in order to do that, you need to think beyond the academy, you need to think beyond the textbook, and you need to be part of the change by adopting language that communicates with many, many more people, starting with the person on the other side of your exam table, the patient.
Thank you. That was very comprehensive. Thank you very much. I'm going to now stimulate thoughts with two questions for Sharon. Number one, everything that Paul said is important. Mr. Paul Conway very actually alluded to. Why do cardiologists and heart patients don't have this problem? I never felt that there was an urge to replace cardiac with heart. And the second one is, what about patient groups that have the keyword renal, like Renal Support Network, a highly credible patient group, and others?
Mm-hmm. I think that in the heart and cardiac space, they're a lot further along in innovation than we are. I think, you hear that all the time. You can turn on the news, someone went into cardiac arrest, and you automatically know what that means, no matter your status or anything like that. And so I just think that they're much further along in innovation. And there have been multiple times that heart disease is promoted. It's one of the #1 killers. And so I think, as Paul has mentioned, we're behind. And so it's important for us to to continue to advance kidney disease, to continue to put the word out there. In my case, honestly, I hope it's hashed out quickly, because I feel like it's holding us up. And so I think, to answer your question, that's why, I mean, you see heart disease, you see cardiac, cardiology, you see all of that more often than you do kidney disease. And so it's just important for us to continue the conversations within smaller groups, within larger groups. It's important for us to put the word out there, to invoke the media to even come into our spaces more, because I feel like the heart space, they do that more than we do.
Yeah, what about then the patient groups that use keyword renal? So one of them actually, or some of them, they imply that they feel in disadvantage if and they don't have resources to change the names of their group from renal support networks or renal support groups to kidney. So do you feel there is an urge to patient groups, on all the remaining patient groups by AAKP, to change their names, to bring the word kidney to their names?
Sharon and I talk about this. So I don't think people have to change the name. I think people are focused on like what's on the letterhead, what's in the article. I think you got to expand the view and say, what is the opportunity here? So more people using language that increase engagement is fine. It doesn't mean the word renal is going to go away. We're not living in a totalitarian regime where we're going to eliminate words suddenly. That's not the point. The point is, what is the language that you're using to communicate the opportunity to drive innovation and to engage patients? And if you have renal on your letterhead, sure, you might want to consider changing that, but you don't have to. That's your call. But take a look at the body of work that you're promoting and the message and the theme, and incorporate things that are more understandable and widen the base, increase the opportunity for engagement in the disease. Sharon had a great point. Bring in the media, and from our perspective at AAKP, bring in the legislators and their staffs. And I'll tell you, given the amount of time they have and the pressure on issues, if you want more money in kidney research, if you want a higher reimbursement rate, you're not going to go in and sit down with a congressional staffer and start talking about EGFR. Let's get real. You're going to talk about kidney failure and the solutions that are needed to serve the underserved patient populations, to bend the curve on diversity issues, and to create solutions. You don't have time for all of the other lexicon. It's not going to be understood.
Thank. That was so well said. Let me switch back to Marva. She has been here very patient. Marva, let me tell you this. So Paul says you don't have to switch from renal to kidney, but consider that. I have received in the past 18 months instructions from some nephrology journals, and one of them, at least I'm aware of, asked me, and I don't think it was an option. They said, change renal to kidney. And I had to do this. And then the other question is why endocrinologists, cardiologists, rheumatologists, why they didn't feel that they needed to change the nomenclature, and they are working peacefully ever since. Why did this come to nephrology? And so, Marva.
Good question. So I think, like I mentioned earlier, the conflation of clear, plain language when communicating with patients versus using the same language used with patients in our scientific discourse. And I think that part is definitely up for debate. I do not for a second debate clarity and plain language when talking to patients. Paul mentioned that people may feel that their status or something may be threatened by changing the language to more plain language. I'm not sure that I quite agree with that. I think we can take the time to explain it to patients, but I see this issue of being more plain spoken with our patients, similar to the issue you raised, Cam, of the task force, of which I was a member, actually, that we recently published our recommendations in terms of removing the race multiplier from calculating glomerular filtration rate. And, looking at those two things together, they are each little pieces of moving us forward in advocating for our patients and what's best for our patients. And I think we're looking at all of these in isolation, and we really ought to be looking at this much more globally, much more as a whole for our patients. So we can sit here and argue and debate kidney versus renal. I think if we make sure that if someone were to slip up and say renal to a patient, that the patient understands that that's equivalent to kidney. Just keep reminding yourself. The same with the EGFR, right? That comes down to EGFR in and of itself is an issue. How are you going to change that? Glomerular filtration rate is how we define kidney function. So yes, we can say your kidney function is at a certain level, which is what I say to the parents of my patients and to my patients. That this is not a number you can hang your hat on. And that's, of course, a whole separate debate about the fact that that's an estimate and people get fixated on it as if it's an absolute number, but different discussion for a different day. But I'm just saying all that to get us to the point of we need to think of how we communicate to patients in general to make it very clear to our patients what we are looking at as we're assessing their health status. What are the things we can offer? What are the things they need to do? Because I think as Sharon aptly put it earlier, it's a partnership, right? In the end, we can prescribe all we want if the patient doesn't buy into it. And I don't even use the term non-compliant because that sounds so patriarchal. I talk about adherence. Are you adhering to the plan that we agreed to? And have the discussion that way. So I just think it needs to be a bigger discussion. Words are a huge part of that discussion, but not the only part of that discussion.
Wow, very nicely said. Our time is up. I was listening and learning so much from each and every colleague here. So I felt privileged. And I hope that those who are going to listen to this panel discussion also, they agree that this discussion is highly relevant and should continue. With that in mind, I would like to thank our panelists for today's great discussion. Thank you very much. Have a nice day.